Today, we are going to discuss a very, very important topic regarding the management of heart failure. The heart failure has been a problem of epidemic proportions in all the spectrum of heart diseases worldwide and more so in India. And over the years, over the decades, lot of drugs and lot of other kind of therapies have been utilized to treat the patients of heart failure. Now, for past 3-4 years in our armamentarium, we have a very good drug which has changed the way the heart failure used to be treated in the years previously. And that drug is an ARNI, angiotensin receptor neprilysin inhibitor, angiotensin receptor blocker and neprilysin inhibitor, which has been supported by a lot of data, trial data, and also now real world patient experience is available, which is guiding us to use this drug more and more in the treatment of patients of heart failure. Our talk of today will be confined and will be focused on what are the evidence that we use the ARNIs in patients of heart failure, and also in what way we should initiate these drugs, and answers to many common questions which are there when the practitioners start this drug in their patients. So let's proceed. As we all know that heart failure is a problem of epidemic proportions. It affects both the quality of life, increases the morbidity, and increases the mortality in the patients of heart failure. Almost in all the cardiac patients, almost who have heart failure, almost 50% of the patients are not able to survive after a span of 5 years. This is a problem of huge proportions, and it affects all ages of patients, be it young age, be it old age, be it males and be it females. Coronary artery disease is one of the most important causes of heart failures. And in India, at any point of time, there are 8 to 10 million patients of heart failure that are there at any point in time. These patients require repeated hospitalizations, repeated emergency visits. It takes a huge toll on the financial burden for the family, and also is a huge burden on the society and the societal and the national resources also. So, as now when we come to scenario in Indian patients, it has been seen that in Indian patients, the patients of heart failure are generally younger and they have got a poorer prognosis as compared to the patients who are there in the Western world or over the worldwide population. So in India, the mean global age of heart failure all over the world is approximately 73 years, but in India, it is 53 years. And these patients are younger and they have a higher mortality rate and higher rates of heart failure hospitalizations. There are 8 to 10 million patients of heart failure in India, as I told you, and that affects approximately 1% of the adult population at any point in time. High admission mortality, very high cardiovascular and all-cause mortality at the span at the follow-up of 5 years. So, what are the goals of therapy? Why do we need to treat heart failure aggressively, timely, and in a way that helps to improve the survival of our patients, helps to reduce the hospital admissions in these patients, decrease morbidity in these patients, and also improve their quality of life. Over decades, many drugs have come to become the mainstay of treatment of heart failure, and over decades, starting from mid-1980s to second decade of this century, we have seen that treatment of heart failure evolve greatly. From the starting, the lanoxin or digitoxin was the one drug which was the only mainstay therapy in the patients of heart failure. Then came the beta blockers, ACE inhibitors, angiotensin receptor blockers. Then the trials were conducted for angiotensin, aldosterone receptor blockers like spironolactone and epinephrine. Then came device therapies, including the therapy for treatment of arrhythmias, ventricular arrhythmias in form of AICDs. Now, the latest in the armamentarium of the drugs which are available to us are ARNIs and along with SGLT2 inhibitors like dapagliflozin and empagliflozin. This has been a long journey, and I would say a very evolving journey and a very fruitful journey. We have gained a lot as far as the options for the treatment of patients of heart failure are concerned, and today we are much better placed to treat our patients with better availability of drugs, better data for these drugs, and better patient outcomes. This is the journey which depicts the large number of landmark trials which have been conducted over the past few decades in the treatment of heart failure, and these included trials for beta blockers, trials for ACE inhibitors, trials for device therapies, trials for cardiovascular resynchronization therapies, and of course for ARNIs and for SGLT2 inhibitors. So with all the drugs that were available, with all the therapies that were available, definitely with the advent of ARNIs, we have taken a huge step forward in the management of heart failure. This was the trial which was conducted for the management of heart failure, which compared the ARNIs for the first time with traditional ACE inhibitor enalapril. And this study paradigm HF trial has come to become the landmark trial among all the trials conducted over previous decades for the management of heart failure patients, and it has shown dramatic and huge benefits with ARNIs in the management of heart failure. In this trial, the ACE inhibitors enalapril in the doses of 10 mg BID was compared with ARNIs in the doses of 200 mg BID. And I would not go into the great details of this trial, would just show you that this was a huge trial which was conducted all over the globe with number of countries and involved different population groups in terms of race, gender, and age. This led to a significant reduction in all-cause mortality, cardiovascular mortality, heart failure hospitalizations, heart failure deaths, and sudden deaths. So this trial established the role of ARNIs in the management of heart failure in patients who had ejection fraction of less than 40%. That is a very important question. Yes, now the guidelines say that all the patients who can tolerate ARNIs, who are candidates for ARNIs, who are suffering from airway dysfunction, who have even ejection fraction of more than 45%, can be administered ARNIs. So all patients who are candidates for ARNIs should be administered ARNIs, and ACE inhibitors should be replaced in these patients. No, we should not wait for the patients to become unstable, and the ARNIs, as we will evaluate, can be started itself when the patient is hospitalized or even in ICU settings also. So there has been a concern among the healthcare practitioners that ARNI should be started only when the patient becomes stable or when the patient presents with acutely decompensated heart failure or a de novo heart failure. Then we should wait the patient to become dry, become eudynamic. Then we should start the patient of ARNIs. But that is a very confusing concept, that which patient to call stable. If the patient is having good hemodynamics, is having a stable blood pressure, is having good urine output, if his renal parameters are fine, then we should put these patients with ARNIs in the hospital settings also. So as far as the level of evidence is concerned, this has become a class 1 indication in patients with heart failure with reduced ejection fraction who are suffering from class 2 to class 3 symptoms, and ARNI should be used in these patients as much as possible. Now the next question that has been answered already partially is acute decompensated heart failure different from de novo heart failure? Acute decompensated heart failure is basically a heart failure in which the patient has been having LV dysfunction, some features of chronic heart failure, and has been doing well on medical therapy, is predominantly asymptomatic. He suffered some kind of insult, and then his chronic heart failure decompensates into an acute heart failure and it becomes symptomatic. These patients are called as patients of acute decompensation of heart failure. The other class is a de novo heart failure. These patients did not have any features of heart failure in the past, did not have any evidence of heart failure in the past. Might be they were having some predisposing factors of heart failure, but now they have suffered a very acute insult like acute coronary syndrome or acute severe MR or acute aortic regurgitation. Now they are first time having symptoms of acute heart failure. So these patients are having de novo heart failure. So it has been seen from the studies, and the very important study to evaluate this question was a pioneer heart failure study, and it showed that even in the ICU settings, in the patients who are having acute decompensated heart failure, provided they are having stable hemodynamics, if these patients are started on ARNIs, they have a significant outcomes in terms of reduction in their NT-proBNP levels also, and in terms of their improvement in cardiovascular mortality and reduction in heart failure hospitalization. I myself also have been using for past 1 year or so ARNIs in ICU settings in the patients who have just been admitted for heart failure management in the ICUs. And if the patient is having normal renal parameters and normal blood pressure levels, I start these patients on ARNIs, and I have seen these patients recovering better and achieving their discharge, and in the follow-up also they are having a better improvement in their LV functions also on follow-up echocardiographies. So definitely if the patient can tolerate and is able to has normal renal parameters, then these patients should be started on ARNIs even in ICU settings. And yes, I already told you that in terms of patient outcomes, if the ARNI is started as early as possible in the management of heart failure, even when he is decompensated or is having de novo heart failure, if he is a candidate for it, then the ARNI should be started to achieve better outcomes, as was shown by the final HF trial, and as has been the experience of many practicing clinicians who start ARNIs early in their practice. The patients, there may be patients of heart failure who are previously on ACE inhibitors, and in these patients, we need to stop the ACE inhibitors at prior to starting ARNI to 50 milligram BID if the patients have been on ACE inhibitors. But if the patients are not have been on ACE inhibitors, then straight away the patient can be started on a dosage of 100 milligram BID also. But keeping in mind the blood pressure levels of the patient, we can start these patients also, start the patients on 50 milligram BID drug also, and slowly escalate, keeping in check the blood pressure levels, the renal parameters, the potassium levels, and slowly we should try to achieve the maximum possible doses of 200, maximum tolerated doses of 200 milligram BID. If the patient is having stable renal parameters, stable hemodynamics, then we should continue these patients on the maximum tolerated dose of ARNIs, that is 200 milligram BID. We generally achieve these doses in patients over 1 to 4 to 6 weeks time, 1 to 1.5 months, and then follow up the patients. Yeah, that is a very, very pertinent question, and it is the most common question that comes into the mind of a physician, that whether the blood pressure will fall if we escalate the dose, whether the patient will develop some kind of hyperkalemia, or whether the patient will develop a derangement of serum creatinine levels. So these questions are valid questions, but sometimes these questions give a lot of suspicion, develops a lot of suspicion in the minds of clinicians, which sometimes is unnecessary and unfounded. We should try to reduce their dosage. We should reduce the dose diuretics. If the patient is all on other antihypertensive drugs, we should lower the dose or stop those antihypertensives. We should, if the patient is on higher the patient is on higher potassium levels, we should try to manage the potassium levels by reducing any aldosterone antagonists that these patients are commonly taking. And we should ask the patient to avoid fruit juices or potassium-rich supplements if from their diet. This is what we should try to do, and to instead of straight away lowering the dose of ARNIs or being afraid to escalate the dose of ARNIs. And even if we are not able to achieve the maximum tolerable dose of ARNIs as 200 milligram BID, even if many patients who are on suboptimal dose of ARNIs, still I have seen my clinical experience that they continue to derive a lot of benefit in terms of their quality of life, and also I have seen many patients they have an improvement in their LV functions also. Yet it is beneficial. Many of the patients who have a systolic blood pressure between 90 to 100 millimeter of Hg continue to take ARNIs at a dose of 50 milligram BID, 200 milligram BID, and there may be a rare patient who is also on a dose of 200 milligram BID. If these patients have near borderline blood pressures and they continue to be ARNIs, there have been studies and also real world experience which suggests that this improves their heart failure dynamics and helps to make them relatively symptom free, and also over a period of time maybe it improves the quality of life also. Yeah, patients with borderline blood pressure should be controlled of ARNIs if they are able to maintain blood pressure between 90 mmHg to 100 mmHg systolic. I already discussed this part, that in the patients who develop hypertension, we should try to look at other things that may be the cause of hypertension along with ARNIs. We should try to reduce the diuretics if they are on any diuretics. We should try to reduce the dosage or stop the other antihypertensive drugs the patient is on. And if at all required, we should slightly reduce the dose of ARNIs, maybe from 20 milligram BID to 100 milligram. And then again, we should try after some time to increase the dose of ARNIs so that the patient can be able to derive the maximum benefit. That is a very important question. That is a very valid point. It has been seen that ARNIs have resulted in improvement in LV function, and when the LV function improves, the requirement of ICDs and CRTs may come down. It is a very valid question, but there has been no consensus statement or no guideline to suggest that it will happen, but that is definitely a possibility that can lead to a reduction in usage of ICDs and CRTs with more and more ARNI evidence with ARNIs regarding the improvement in LV function becomes available. I would say I think in my clinical experience, I would say at least 40 to 50% patients of heart failure LV dysfunction must be having diabetes or impaired glucose tolerance or elevated glycosylated hemoglobin levels. In whatever way they present, I think 40 to 50% of patients would be diabetics in some way. Do you believe that ARNI has ancillary benefit in new onset diabetes and in reducing the need for insulin? There have been studies, yes, there have been studies. I will share a few studies that diabetes in diabetic patients, yes, the use of ARNIs has led to a reduction in CV mortality and heart failure hospitalizations. Similarly, as to the patients who had no diabetes, and in diabetic patients, it has been seen that there's also a better effect, incremental effect on better glycemic control in patients who are on ARNIs, who are diabetics and having LV dysfunction. There is less use of insulin, 30% lower use of insulin with ARNIs as compared to enalapril in the study, and fewer patients were required to be in OHAs when they were started on ARNI for the treatment of heart failure. ARNI showed such promising results in patients with LV dysfunction. It was evaluated whether the ARNIs can be used in patients with heart failure with preserved ejection fraction. That is the patients who had a EF ejection fraction of more than 45%. And a study was conducted, which was Paragon HF trial, and it showed that even in patients with preserved ejection fraction who had a EF of more than 45%. These patients had a better patient outcomes with ARNIs in terms of reduction in the heart failure hospitalizations and also CV deaths. So yes, ARNIs are beneficial in patients who have a near normal ejection fraction, but it has still not found the way in the guidelines. But we hope that ARNIs will also have an important role to play in patients who have heart failure with near normal ejection fraction. There have been studies, there have been trials, important trial was Paragon HF trial, which showed the benefit of ARNIs in patients who have a preserved ejection fraction. So ARNIs will definitely, in times to come, will have an important role to play in these group of patients also. Most important contraindication or for the use of ARNI is a deranged kidney function test. The patients having elevated creatinine levels, low GFR, and having hyperkalemia. These patients are the patients who are in whom the ARNIs are contraindicated, plus the patients who are hemodynamically unstable, who are in shock or are hypotensive. Then the ARNIs also are a risky drug to use in these patients. So while using ARNIs, we carefully monitor the blood pressure of the patients, also the renal parameters and potassium levels of the patient. (10 to 15% of patients who are having heart failure will have some contraindication to use of ARNIs, because many of these patients are diabetics and have a renal disease along with it. The patients who are having low EGFR, who are in a stage more than a stage 3 or 4 CKD, then the ARNIs would be a difficult drug to use in these patients. And many patients of heart failure are having some degree of renal dysfunction. And the patients who are having shock, cardiogenic shock because of heart failure, the patients who are dependent on inotropes or some kinds of ventricular assist device and are in need for cardiac transplantation, also in these patients, the ARNIs would be difficult to use. So overall, I would say maybe 10-12% of the patients in my clinical practice would be the patients of heart failure who would not be able to receive ARNIs, or it will require a lot of caution to use ARNIs in these patients. First of all, in the patients, hyperkalemia, we should know what is hyperkalemia, what level of potassium should we call hyperkalemia. Sometimes we will treat the level of ever 5 as hyperkalemia, some treat level of 4.5, 5.5 as hyperkalemia. Clinically symptomatic hyperkalemia, which can cause significant problems for the patient, is the potassium level of more than 6. Less than 6 is easily manageable. If the patient is having potassium level of more than 6, we should stop any confounding drugs the patient is on. Most of the time, these patients are on some kind of aldosterone antagonists, which they are receiving along with their loop diuretics. That the patient should be stopped. That these antagonists should be stopped. The patient can be given potassium binders to treat their hyperkalemia, and also they can be managed with traditional. We commonly use insulin dextrose infusion to treat hyperkalemia. All these ways of treating hyperkalemia can be employed in patients with ARNIs. ARNIs can be stopped temporarily in these patients if they have significant hyperkalemia. And when the potassium levels becomes normal and the renal parameters are normal, then the ARNIs can be restarted in the lower dosages, and slowly the trial should be given to start the dosage, increase the dosage of ARNIs. We have seen in our clinical practice, I have personally seen that many patients have a significant improvement in their LV functions when they started ARNIs over a period of maybe 6 months' time. And then the question arises, because the ARNIs are still costly drugs in India. And so the question arises that now when the patient is asymptomatic, his LV functions has improved, he's normodynamic, he's having good quality of life, can we reduce the dose of ARNIs or can we stop ARNIs? So in my practice, I have not tried to stop the ARNIs in these patients. Maybe I have reduced other drugs. I have stopped giving them any kind of diuretic. I have stopped giving load if they're maintaining a normal heart rate. I have stopped or lowered the dosage of beta blockers in these patients. I have stopped linoxin in many patients, but I continue to use ARNIs in these patients and convince them to continue the ARNIs. Some patients are reluctant that it is expensive drug, but still I try to convince them that ARNI should be used continuously because it can lead to a relapse in their heart failure and functions can show a deterioration over a period of time if the ARNIs are reduced. So even if the LV function improves, we should, as far as possible, continue the patient on ARNIs. As far as possible, there have been evidence to show that if the ARNIs are stopped, the heart failure symptoms can relapse, the LV function can start to deteriorate again. So as far as possible in these patients, even if the LV function improves, we should try to continue ARNIs in these patients.